All right. Well, good evening, everybody. Welcome to the November 2024 Virtual Tumor Board. It is Wednesday, Election Day, or day after Election Day, excuse me, November 6th, 2024. Great session on tap tonight. Thank you so much to the Endocrine Service. They always rally to the cause, and really excited for a stimulating session this evening. Thanks to Alan Ho from Cedars-Sinai, who is a lead organizer and will be moderating the session. So Alan, thanks again for your help in setting this up. Just for those who aren't familiar with it, this will be 3 cases, 20 minutes each. I'll kind of step into the background and monitor the chat box. If you're not talking, please mute if you can, just to minimize the background noise. And then if you have questions, please enter them in the chat and we'll kind of pose them to Dr. Ho and he can bring them out to the group discussion. So thanks so much for attending and look forward to a great session.
Thanks so much, Michael. I'm going to post my form here. Excuse my laryngitis. We'll be able to get through it just fine. I really want to welcome everyone to the Tumor Board today, not just our fellows, but also their associated faculty for taking the time, and also our expert discussants, our esteemed discussants who need no introduction. We're going to focus on thyroid cancer from simple to complex. The first case will be an intradermal thyroid nodule presented by our folks at Ohio State University, Dr. Noel and Agrawal. Case 2 will be a medullary thyroid carcinoma case with Drs. Chow and George from UCSF. And then case 3 will be a case of anaplastic thyroid carcinoma with Drs. Kobayashi and Wong from MD Anderson. I want to spend just a second to really thank wholeheartedly our expert discussants who will be providing some input and just their experience just over the course of their many years of service. Ellie Magami is my friend and colleague from the City of Hope just across the way. She's the Norman and Sadie Lee Foundation and Tao Chair, and also Chief of the Division of Head and Neck Surgery. And Dr. Ashok Shaha, also who I consider a dear friend and mentor from Memorial Sloan Kettering. He's the Jayton Shaw Chair in Head and Neck Surgery, Professor of Surgery at Cornell University, and not to be underestimated, the former president of the American Head and Neck Society, as well as the American Association of Endocrine Surgery. So with that, I'm going to let Chris Noel take it away for the first case. Go ahead, Chris.
All right, thank you. I just need you to stop sharing, and then I'll be able to pull my slides up.
There you go. Thank you.
Thank you. All right. Well, thank you for the opportunity. For Tumor Board today, we have Ms. M. She is a 70-year-old female, and her past medical history is as described there. And she presented to us with a sort of long standing history of a right-sided thyroid nodule. This had been initially picked up over a decade ago, incidentally, on a routine work physical. She has no risk factors. She had an FNA done at the time that was indeterminate, and she was followed by an endocrinologist annually with ultrasounds for about 5 years, and ultimately discharged from surveillance. Things were well up until about a year ago when she developed an unexpected 25-pound weight loss. And as part of that workup, her GP ordered various thyroid tests and referred her to us for our assessment. On exam, she has a smooth, mobile, right-sided thyroid nodule, no adenopathy that we can palpate. She's got normal vocal cord mobility on the NP scope. I have the video here from our in-office ultrasound. You can just take a look at the nodule, and got a still image there that I think is sort of representative, as well as the formal radiology read. I've sort of pulled out the salient features here. So it's a 2-centimeter right-sided nodule with multiple risk features, ultimately classified as a TI-RADS 5 nodule. The patient came to us with an FNA, which was reported as being suspicious for malignancy, or Bethesda 5. And they also came to us with molecular testing. So it's patients' pherma results. Notably, they have an isolated TERT mutation, which is interpreted by the pherma group as portending about a 90% chance of malignancy in the indeterminate thyroid nodule. And just for context, it's not just sort of risk of malignancy, but it's known that TERT is sort of a high risk molecular profile feature with, I sort of just pulled the relevant figure that we think we all know well from the ATA.
And Chris, can you just clarify, for the past 5 years, it's grown from about 2 centimeters to about 2.4, roughly? So
Yeah.
pretty modest growth.
We don't have the original imaging, so it's 2 per the patient, and it's 2.4, so no substantial growth, and really only reinvestigated because of the unexplained weight loss. Additionally, so we ordered a CT scan. I don't have the whole image with us, but I just sort of pulled a sort of relevant slice, and it sort of redemonstrates the right side nodule. It doesn't have any appreciable extrathyroidal extension or any evidence of cervical adenopathy. So I guess our questions to the group are, at this point, is there anything else that you would want to gather, any more information, and what would sort of your management strategy be? Is this someone you would offer surgery to, and if so, what extent of surgery?
So this is a very interesting presentation, a very interesting set of information that you've been given that may or may not be what maybe the rest of the tumor board may ordinarily do. So if I could ask Dr. Magami, just as a preliminary, big picture sort of scenario, is there anything that strikes you as usual or unusual about this case?
Thank you, Alan. I wanted to thank you personally for including me in this panel. It's really great being here with my old mentor, Dr. Shaha, who taught me pretty much most of everything that I know about thyroid.
My mentor, not old mentor.
So it's a really great pleasure being here and being with some of the new faculty and fellows here. It's just wonderful. Thanks for including me. So regarding this case, you have a 70-year-old woman with typical comorbidities who presented really over 10 years ago and was being followed diligently for about 5 years with her endocrinologist, with no symptoms, no interval change, annual good follow-up, and in the background also there wasn't anything that would indicate higher risk, and no significant family history, no personal history of radiation. So everything seemed really favorable. And then this 25-pound weight loss came about, and to be honest, I don't know what to make of it. I'm curious about that as a side note. I don't think it's related to what's going on with the thyroid, but you get connected to a new provider and you have that history of weight loss, and then the GP appropriately investigated with an updated ultrasound. The thing to notice about the ultrasound, there hasn't been really significant change in size over all these many years. And when that was further explored with CT imaging, you don't really see anything that would indicate that the nodule is behaving in an aggressive way. There's no evidence that there's extrathyroidal extension, adhesion to the tracheal wall or esophagus. And as I understand it correctly from the presentation, there was no evidence of metastatic nodal disease. So all in all, it appears that it was a very indolent situation and relatively quiet without any significant changes over all this time. So the needle biopsy was driven by the high TIRAD score that was given, and I guess the size of the lesion. And so you have a Bethesda 5 designation, which indicates suspicious for malignancy. And, at this point, at my institution, at least, we have a surgical consultation and a consideration for diagnostic lobectomy or ongoing observation. And to be honest, we don't go straight to molecular testing in this setting. So I don't know what prompted the FIRMA testing. I'd be curious to find out about that.
Chris, do you have any context about why, as Dr. Magami rightly points out, there was a FIRMA testing? for a Bethesda 5 nodule.
The patient came with it. So it was all done by sort of outside providers, and we were sort of confronted with all this new information.
Okay. I will give you a bit of a sneak peek. Medicine is changing. We're in 2024. Next year in 2025, there will be new guidance from the ATA guidelines, specifically on thyroid nodules. There is a lot of lobbying by the molecular testing companies to actually pursue Bethesda 5 molecular testing. The article you actually suggested that everyone read really pushes that Bethesda 5 nodules may benefit from undergoing molecular testing to better characterize whether someone should get a hemi versus a total versus further workup. So next year there'll be further guidance on this, but the field currently is very split on whether one should pursue. But in 2024, I would consider it to be unusual to undergo molecular testing. And it sounds like, Chris, you agree, right? And Dr. Agrawal, this is not something you normally see in Ohio every day. Okay.
No, definitely not kind of how it presented, but yeah, definitely kind of threw us down a pathway with the molecular alteration in this particular patient. So
right, Dr. Shaha, you've been presented with this unusual case of a 2.5 centimeter nodule with a TERT mutation and a Bethesda 5 cytology. How would you answer the question about what kind of surgery you would offer, if any?
Yeah, I think that's a great question, and I have my own philosophies and thought processes. TERT alone is difficult to interpret. And Chris showed that the graph, with the arrow pointing to from low risk to high risk. But if you read that, it is BRAF and TERT. We know very well from the many publications, BRAF and TERT is the worst diagnostic. I'm not going to say it is the worst prognostic, because it all depends upon the clinical findings. Now, what is good in this lady? She has a nodule for a long time. It is well defined. In his description, he said it is a soft nodule, not fixed. And the only thing that is bothering us is the thyroids, which is appropriate. I don't disagree with that. And needle biopsy, which is reported to be Bethesda 5, which is suspicious. And then we are putting the TERT in it. We have had several patients with the TERT and RAS or TERT alone, and they turn out to be benign. So I just want to throw that in the discussion, that I won't make even though, Alan, you made a comment that the new guidelines are going to discuss the extent of thyroidectomy. I don't think we are there to say, I'm going to make a decision about extent of thyroidectomy based on the mutations alone. There are good clinical findings. The clinical judgment and clinical findings are very critical in thyroid. And in this lady, there is hardly any reason, in my judgment, to do a total thyroidectomy.
Be that as it may, the Bethesda 5 and TERT mutation make it a near sure thing that it likely is cancer. And Dr. Shah, you would agree across the country, there is a spectrum of opinion, and you would be rational to offer either. Would that be true?
Yeah, I think you are right. I mean, we are using too much of mutations, and making clinical decision. Keep in mind, this lady is 70. She has a nodule for a long time. All that we are trying to push is a diagnostic and therapeutic lobectomy. That's why I changed the word. It's not only diagnostic, it is therapeutic in most of the cases, unless the final pathology report comes very aggressive cancer or widely invasive or major angio invasion. I think I'm very comfortable in this lady with a lobectomy alone. Her quality of life will be much better with lobectomy. And we're doing it because of the thyroids and because of the needle biopsy.
Great, thanks. Ellie, really quick before we move on, would you offer a hemi or a total with this information?
In this particular situation, it would be a hemi.
Okay, perfect. All right, let's go ahead. Let's move on and see what happened.
So I would say there was some shared decision making with this, and with consultation with the patient. They preferred to have a total thyroidectomy. So that is what we went through with, and the pathology came back as benign. the follicular thyroid adenoma with papillary architecture and oncocytic metaplasia. And I think it's worth noting that we had two sort of very experienced head and neck pathologists at the Ohio State review this, and they sort of both came to the same conclusion. And I think we've already had a lot of good discussion around this, but Dr. Agarwal and I were thinking sort of how to sort of structure this case and summarize it. And I think if we sort of draw on Bayesian principles, which are I think very relevant to this setting, that sort of we can summarize the issues. So I think our prior belief, just based on the history and physical exam with it, was that this was a lot of nothing. Like this was very unlikely to be cancer. Our pretest probability was low, but we were confronted with all this data that we didn't necessarily request, but was provided to us anyway. And I think all those suspicious features sort of led us down the path of surgery for a patient who's had a nodule that hasn't really grown in over a decade. And then, we were told that it carries a 90% chance of malignancy, but in the end it was benign. And I guess our thoughts were, in an ideal setting, should there not an ultrasound not have even been put on this lady's neck? Should we have just continued to sort of clinically observe? Alternatively, does TERT sort of portend carcinogenesis and eventual cancer? Like, is it that a TERT mutation in a follicular adenoma will invariably turn into follicular carcinoma and we sort of caught it early? Or I just kind of curious what people think.
Go ahead,
I don't
Ellen.
think we have any
Yeah, I was-
data to prove that just because it is turned positive, it's going to turn into aggressive cancer. I don't think we are ready for that answer today.
Yeah, I agree.
Yeah, I was gonna make a point is that I think we have to be careful not to extrapolate what a certain molecular test is designed to do, because, for example, TERT promoter mutations along with BRAF, like Dr. Shahar was saying, that's in the context of known papillary thyroid cancer, that it's associated with worse prognosis. Here we're extrapolating to the pre-diagnostic space, and that doesn't kind of quite translate. Similar to kind of also being careful to extrapolate data from the diagnostic space to diagnose indeterminate nodules to the prognostic space. I think the field is trying to merge the two, and the boundaries are quite blurred, and I would caution against that.
I couldn't
Recently,
have said
we
it
had about
better.
4 or 5 patients with the TERT, and they came here with a strong recommendation of total thyroidectomy. And based on the clinical judgment, we decided to do lobectomy, turned out to be benign. And not that we did something different, but we just went with the clinical judgment. The clinical judgment is so critical in thyroid. Based on the ultrasound, your clinical finding and intraoperative findings. You may change in the operating room if the tumor looks very nasty, or there are 10 positive nodes. Yes, I would change it.
I think this is highly educational for the fellows, just to calibrate how we feel about TERT. And as Dr. Shah is intimating, a really aggressive cancer sometimes is staring you at the face, right? It's going to be big. It'll have lots of lymph nodes. It'll look very aggressive. Chris, I really like how you use shared decision-making. Amit, you have clearly trained your fellow very, very well in terms of how this was taken care of. So Amit, do you have any last words before we move on to the next case?
No, I just thought it'd be a great case to share with the group, just because of kind of, merges a lot of what we're kind of learning in the current day and age about molecular medicine and thyroid cancer, and kind of how you can be led down a certain way. But the clinical, like Dr. Shah said, the clinical features really kind of overshadow everything in this particular case. Maybe we could be criticized for being a little over aggressive with this patient. Of course, but I think in the end result, we still followed a pretty reasonable algorithm for getting them to where they needed to be. So,
Absolutely. All right, thanks, Amit, and thanks, Chris. Let's move on. Oh, yeah,
Yes. My daughter's a proud Buckeye.
Cute.
So adorable.
Congratulations, Chris.
Oh, thank you.
Great. Maybe we could, to keep things moving, move on to Michael, also with a similarly fascinating case. Maybe you could show your slides and we can go from there.
Sounds good. Everyone can see me, yeah?
I can see you.
Fantastic. But thank you everyone for the invitation. Really excited to get to hang out today and chat about this case. And I hope it stimulates as much discussion as we had when we first went over it. As a 41-year-old, exceedingly healthy male, he had an 8 to 10 month history of an enlarging thyroid gland. Wasn't something that had really been brought to his attention before, but his wife had noticed some like changes in photographs. And what really brought it into focus was he had an episode of anterior neck pain, which resolved spontaneously over the course of a month, but it did cause him to start thinking about investigating into it. A bit of a confounder, he also had a single disabling vertiginous episode at this time that lasted about 3 hours, but he did not have any headache, vision changes, palpitations during this time, and he never had any symptoms again. He's otherwise doing well, no dysphagia, dynaphagia, difficulty breathing or changes in voice, and there was no recurrent neck pain or restriction of motion. He also has no personal history of radiation exposure and no family history of cancer. On physical exam, he's thin, healthy. He's an ultra marathon runner. He did have moderate right greater than left visible neck asymmetry with a palpable thyroid gland, but it was overall mobile and non-tender at the time of exam. He also did not have any obvious lateral neck lymphadenopathy, and on scope, he had normal vocal fold motion. An outside provider had obtained an ultrasound and an FNA, and this is the information we had when he arrived in our clinic. The ultrasound from the outside read did show a dominant 6.7 centimeter right TIRADS 3 nodule, as well as a TIRADS 4 on the left, and the FNA was consistent with medullary thyroid carcinoma in both. So here's a representative image of that right-sided nodule.
Do you think maybe you could spend,
I'm so
never
sorry.
mind.
Go ahead.
Do you mind describing it a little bit, Michael, in terms of the sonographic findings? Anything strike your eye?
So I think it was a heterogeneity, which was really striking. When we looked at it in clinic, it definitely, like, despite being TIRADS 3, it looked suspicious overall. And I think it's one of those things that, although by diagnostic criteria, it's one thing, it doesn't necessarily pass the gut check. But again, we're obviously biased because we also had FNA information on arrival, but it looked worse than the ultrasound report described as well.
Yeah, if you didn't have the FNA, you would just say it looks highly atypical, just very ugly.
Yeah. I would be concerned had I just seen that ultrasound in clinic, and that was my first bit of information. I still would be highly concerned for cancer, even with a reassuring read from elsewhere. Oh, I'm sorry, that looks like I canceled sharing. My apologies.
Oh, no, we can still see you.
Oh, you can still see it. Okay.
Yeah.
So we obtained a CT scan, which did show a 7.6 by 6.1 by 6.4 heterogeneous enhancing mass centered in the right lobe of the thyroid. It did have some minimal substernal extension. There was a lot of displacement, but there was no definitive invasion of the trachea or extrathyroidal extension. There was also a finding of a rounded lesion in the right palatine tonsil, which our radiologist could potentially hint of metastasis, but there was no other enlarged nodes seen in the lateral neck itself. And then there were some pulmonary nodules that spurred further investigation as well. Here's the image, some images that we had on CT, kind of showing just kind of how large and heterogeneous it is, as well as kind of hinting at the depth that we have on that right side. And here's a coronal image as well, just showing a little bit of that displacement of the trachea. We also obtained a PET dotatate, which obviously did have a avidity in the primary tumor itself, but just to confirm those lung nodules, we also did have a right pleural base nodule as well as a right upper lobe nodule, which was PET avid. And here's some representative images there. So when he first came in, obviously we wanted to continue a workup. We have a proprietary molecular studies here, which we were hoping to send on the FNA slides, which came over with us. And we also ordered him a germline mutation genomic testing, but he actually canceled these studies as he was seeking multiple opinions. But we were able to get labs from him that day. Calcitonin was above 1200, CA was at 125. Normal calcium and urine metanephrines were negative, with overall a low concern for multiple endocrine neoplasia. Although we did want to be sure, given that he had that odd vertiginous episode, and we just wanted to make sure he wasn't having like palpitations or an episode of like a hypertensive urgency at the time, but it did not necessarily seem so. And the lab seemed to back this up. So when looking at this patient, we staged him as a T3A N0 M1, and which put him at stage 4C. And so some of the discussion that we had, obviously a total thyroidectomy and central neck dissection would be indicated, but given the large bulky disease without definitive lateral neck nodes, is an elective treatment of at least the right side on the lateral neck something that people would pursue up front, or is that something that could be addressed later? Obviously, the calcitonin would be tough to follow as we have concern for distant mets, and so it wouldn't necessarily be a reliable indicator of disease control and whether or not in terms of guiding decision making for the lateral neck. And then we also were hoping to kind of discuss the considerations and timing for systemic treatment, looking at TKIs and obviously if we had the information for RET testing, kind of guiding which agents we would use and whether or not it's something that would be neoadjuvant or adjuvant after the surgery.
Great. Thanks, Michael. This is a very, very interesting and timely case, given all of the new advances in the past few years. Let me start with Ellie Magami. She and I are not that far apart. She's an outstanding thyroid surgeon. I've seen her outcomes firsthand. And I know that she can manage a lot of these complicated cases. So Ellie, why don't we start with the first question? Given all you found, would you consider elective treatment of the lateral neck?
I appreciate you, Alan. I feel the same for you. The one thing is there was a brief mention of potential metastatic lymph node by the palatine tonsil. I wonder if there's a retropharyngeal lymph node, in which case the nodal staging will be impacted here. And it also increases my concern for more extensive lateral compartment nodal disease. The calcitonin level is very high, and that also increases my concern for regional nodal disease. We know that there are suspicious lesions in the lung, and this patient has distant metastatic disease. But the calcitonin is extremely high, and that worries me in the lateral neck. I know imaging was done, and they didn't see anything that looked obviously suspicious for metastatic disease. But I think if you're going to go for surgery first, you should get a sense of whether you're dealing with retropharyngeal metastatic nodes or not based on that CT, and if appropriate, do the right-sided lateral compartment neck dissection. Now, with a calcitonin so high, would I advocate for doing the lateral compartment on the contralateral side or not? Depends. A guideline suggests when the calcitonin levels are really high, you may want to give the contralateral neck a go too, but again, this is in the context of distant metastatic disease as well. But when I look at the lung lesions, they're small, they may be limited. So although this patient does have metastatic disease, the burden of metastatic disease in the lung seems to be somewhat limited. And so that might push me to take a more aggressive upfront approach in the neck by doing at least an ipsilateral neck dissection when I do the total thyroidectomy central compartment node dissection. I don't know if that answered your question or not.
Sounds like you'd favor it. It sounds like it. Okay. Dr. Shah, when I was training with you, there seemed to be a push to do elective lateral neck on dissections properly in an effort to minimize the calcitonin as much as possible. Is that relevant in a patient with distant metastatic disease? What would you do in this scenario?
Is it relevant? The answer is no. But is it practical? Yes. There is a big difference between the hypothesis and sitting in a conference and the practical approach. This patient has a huge thyroid mass. Your incision is going to be on the sternomastoid. You're going to look at the jugular vein. And taking out the lymph nodes from the right side, selective neck dissection, is not going to add much to the morbidity, but will give you a good understanding of what is happening in the neck, which you may not see on an ultrasound or CAT scan. And I think I would definitely consider that. I know we publish, and I know MD Anderson published against the elective nodal dissection. This is practically not the elective nodal dissection for 1.5 centimeter medullary cancer. This is a huge medullary cancer. You're going to look at the whole neck. Would I do on the contralateral side? No, I would not, because that is just going to incur more morbidity to the patient. I would do ipsilateral so that down the road, I don't have to keep worrying about it. Keep in mind, this patient is going to undergo $1 million workup in follow-up. He's going to get many ultrasounds, a CAT scan, a PET scan, etc. And I want to resolve once and for all that the calcitonin is not coming from the lymph nodes, because I already done it. So whatever is happening to the calcitonin is happening from distant disease, lung, liver, wherever. So that's a practicality. Would I do it? Yes, because I'm going to open the neck to see the whole area. I would definitely do it.
Excellent. You just want to be as comprehensive as possible to alleviate any doubt. Dr. Shah, I noticed that the tumor was very bulky, as you mentioned. Let's assume that the tumor is RET negative, and you decide to proceed with surgery, given how large it is. How would you address that recurrent laryngeal nerve? It looks in play on the right side. Which side would you do first? Would you sacrifice it if it were encased?
That's a great question. That's $1 million question. I'll give you my perception. I would be, again, nerve monitor is very integral in this case, so there's no doubt about that. I don't think we're going to argue about it. I would go on the right side because that's a bigger disease. But when I go in the tracheoesophageal area, if I find the tumor is intimately married to the nerve, and while dissecting, I'm likely to lose the signal, then I would go on the other side, take out the other side, make sure that I preserve the nerve on the other side. Now, this is what I call the 20% or 30% loss of signal on the right side, where the bigger tumor is, because of the nerve is intimately adherent to the tumor, and you may lose the signal. Remember, there is a big difference between losing the nerve and losing the signal. Any dissection, you can lose the signal, and that will prevent you to go from the right side, left side. So once I know the tumor is adherent or there are lymph nodes adherent to the nerve, I will go on the other side, where the risk of losing the signal is only 2% or 3%. Finish the left side and then come back on the right side. You lose the signal, not a big deal, as long as you have preserved the whole nerve, integrity of the nerve.
All right. Now, Ellie, he's 41, young guy, ultra marathon runner. Probably wants to preserve his voice as best as possible. Let's say you did as Dr. Shah said, but the nerve is encased. Do you sack it or do you save it?
So what's the RET status on this patient? I'm in surgery right now.
We're still assuming he's RET negative. Still
So
assuming he's RET negative. Yeah.
Yeah, it's RET negative, and the nerve is encased, and I have to sack the nerve if I'm going for the whole right thyroid lobe. Is that what you're asking?
Yeah, or you could
Yeah.
leave some tumor behind.
Yeah.
He's got distant metastasis.
It's difficult sometimes, as you know. It depends. If the nerve is grossly invaded, then obviously you take the nerve. But the patient has vocal cord functioning at the beginning, so that's a good, hopeful sign that there might be a chance to save this nerve. So if you get in trouble with a nerve dissection on the right side, and you get to a point where it gets kind of hairy, and you may lose signal going any further, I do exactly what Ashok said. I go to the other side and try to do the easier side and get the contralateral operation done and out of the way while I'm still kind of in a good state of mind, and then I return to the right side. If I can save the nerve, I do. If the nerve is encased completely and there's gross disease on it, and it's just the other side is preserved, then yeah, I take it.
Yeah, it's definitely a judgment call. And then of course you can consider like an ANSA, anastomosis, or some other kind of a nerve reanastomosis in that scenario. Okay, so let's go back to Dr. Shah. Let's assume this is a RET positive tumor. Let's say on germline somatic mutations are positive for RET, and we are in 2024 with some real killer drugs out there. Would you now consider a different approach given this information?
Yeah, I think we have switched quite a bit, because we have learned a lot about selpercatinib and rate mutation, which can be practically done in a few days. This patient has a huge tumor. He has pulmonary metastasis. Very unlikely we are going to cure him by any surgical means. So in this particular case, I would always get an opinion from medical oncology, and I will be leaning towards starting him on selpercatinib and see how he responds. But I would repeat the CAT scan in about 6 to 8 weeks and see the response. If the response is great, I would continue for 3 to 4 months and then operate on the patient. If the response is poor, the calcitonin, keep in mind, when you start these patients on medullary cancer with high calcitonin on selpercatinib, the calcitonin comes down very rapidly. But you need to have a demonstrable reduction in the CT scan. And the best way to do this is a CT scan, because you yourself as a surgeon know what is happening. You can get a better idea. The ultrasound is good, but won't give you a comparison, which you can do in this case. So I would definitely, today, I'll get a medical oncologist involved. We have seen some great results. Whether the surgery will be relatively simple, whether the nerve could be more likely to be preserved, I don't think we have answers to that.
Thank you. I'd like to get some of the other faculty's opinions as well. Jen or Jonathan George, thanks for coming. Or Amit. I know that MD Anderson, for instance, has a protocol with selpercatinib, an ongoing trial. Would this be an appropriate candidate to start induction?
Yeah, I think if there is concern about a recurrent laryngeal nerve encasement in a young patient, that would be a potential trial candidate.
Okay, perfect.
Would it be, is it a neoadjuvant approach? Would you, since the patient has distant mets already, would that be a neoadjuvant thing, or would you the only, and if there's potential for local disease invasion and distant mets, would there be is the trial for a neoadjuvant approach to RET medullary thyroid cancer, RET positive?
Yeah, distant disease is not an exclusion criteria. So I think, obviously if the patient has a really, really high burden of distant disease, we may be concerned that a neoadjuvant approach may not be ideal. But here I think that, the intent would be to perform surgery after neoadjuvant treatment.
Great. Jonathan, I saw that you guys got a PET dotatate scan, which is oftentimes suggested. Can you tell us your experience with PET dotatate versus a standard PET CT? I found that the efficacy is quite mixed, but perhaps you know better.
No, I actually don't. This is not my patient necessarily. This is Michael. Michael has this case. It must be another provider, but I tend to use CT neck and PET CT in generally. So as Ashok said, the fine cut CT neck or with contrast pre-op always, and sometimes an MRI, but PET CT, it's standard PET CT. I don't have much experience with PET dotatate. Michael may, in having made this. Do you know, Michael, if what the advantage was for PET dotatate for this?
Oh yeah, I saw the patient, and I actually discussed him with Dr. Ha, and kind of like Dr. Ho mentioned, dotatate does sometimes offer a little more information for the neuroendocrine side of things, and so he favors PET dotatate, and so then that's why we pursued it in this particular instance, especially with the pulmonary nodules. We felt that there might be a little more sensitivity there, and give us a little more information in this case.
I think the dotatate is more helpful in carcinoid tumors rather than truly medullary thyroid cancer. I don't think we have good information comparison between the regular PET and the PET dotatate. But for carcinoid, I think dotatate is very good.
Yeah, and I think the take-home message is a PET CT probably is just fine for medullary thyroid cancer, at least in 2024. Great. Michael, any other questions? I lost your slides there for a moment.
Oh yeah, sorry. It like took away all the people's pictures, so I just stopped.
Oh, it's okay. I think we were pretty much there.
Yeah, I mean that was the main question. I think there was just like when we were having the discussion for the lateral neck when we talked about the tonsil lesion, it was like within the tonsil and was not PET avid, and so we did not necessarily buy into like we weren't as concerned for a lateral neck like disease, and so we were actually looking at the MD Anderson paper and we're like, are we treating ourselves more than we're treating the patient? And so that actually was a nice point of conversation for us. But we agree with both Dr. Megami and Dr. Shaha on that. From a practicality standpoint, we would just be kicking ourselves if we had to revisit that neck after doing such a large resection anyways. And so I think everyone's knee jerk is to, treat the neck. It's both, like, as with the nodule, it's both diagnostic and therapeutic potentially. And just does give you help guide your treatment moving forward. And if that's clean, you can focus a little more thoroughly on the distance disease and potentially get other services involved, like to kind of hone in on the last site of disease. So that was ours as well. And then kind of as you mentioned with the TKIs and the RET status, is like we've moved towards neoadjuvant for a lot of tumors, and it's been very, very helpful. But I think that we ended up going more towards he's 41. He's got 2 young kids, and we would go for broke from an oncologic standpoint and prioritize getting the tumor out, even if that meant a nerve sacrifice. And we wouldn't delay treatment necessarily for immunotherapy, although we certainly think it has a role in his overall care.
Great, very well, very well put. Dr. Shaha, last word. You've seen dozens and dozens, if not hundreds of these patients. What's your hunch? Is he going to live?
I don't like to predict anybody's life, but he's not going to be cured.
Yeah.
He will continue with the mild hypercalcitonemia. His future is going to depend on 3 things. Is he going to recur in the thyroid bed? Number 1. Is his pulmonary metastasis is going to increase? And the only way you will be able to find is with a follow-up PET scan and the calcitonin. If his calcitonin post-operatively is below 100, I'm very, very happy. If it remains 900, then there is a bulk of disease still in his body. Either it is in the lung or the liver or any other part of the body. And the liver metastasis may be difficult to find because these are small metastatic disease on the surface of the liver, and the imaging won't show you. So you just have to follow the calcitonin. Would he live for 10, 15 years? Probably yes. Now with the treatment that we have with the selpercatinib, I think they can live much longer.
Excellent, excellent. Great. Let's with that in conclusion, let's move on to case 3. Kenji, thanks for putting together the slides and the case today. We'll hand it off to you.
You guys see my slides?
You can see it.
All right. So our case is a 47-year-old female. She first noted a right-sided neck mass in October of last year after a little viral kind of head cold issue. But then that began to rapidly grow to December. She started to complain of progressive hoarseness and dysphagia, some difficulty breathing when laying flat, had a 20-pound weight loss over that period. Had an outside ultrasound that called a Thyroid's 5 nodule and an FNA that called anaplastic thyroid cancer with sarcomatoid features. When she presented to us, this was her flexible fiber optic exam, demonstrating a lot of supraglottic edema and some limited vocal movement on that right side. So we got some imaging. She got a CT, neck and chest, an MRI brain, and a PET scan. This is a couple slices of her CT neck where you can see a large right-sided thyroid mass that kind of pushes the great vessels posterior laterally and pushes the trachea to the left. And then here is a screenshot of her PET scan demonstrating diffuse metastases. So really tough situation at this point. So I wonder if anybody has any thoughts on kind of where we go from here.
Great, Kenji. Ellie, if you can see those images, looks pretty horrific. how would you go about counseling this patient, and what would your next steps be?
I got a prayer that it's BRAF positive, Alan. So my heart sank when I saw that PET scan. It's awful. So we need to obviously expedite BRAF testing for this once we know it's anaplastic. That's like a very high order of priority for us. And you can do that with immunohistochemistry on the needle aspirate to get a quick kind of answer. Some people might do blood testing, as well, and that might have a faster turnaround time because the next generation sequencing, as you know, takes a few days to result. And then when I look to a patient like this, obviously as a head and neck surgeon, main concern is airway. I know she has some airway symptoms, but I don't know how dire it is. My fear always is when I deal with patients like this, that they have such a dire airway, distress that I have to do something and do a tracheostomy. I try to avoid tracheostomy as much as possible because obviously a lot of times you have to cut through tumor to get to the airway. Maintaining that tracheostomy tube is very problematic. The two big extrudes, there's bleeding. It also provides a conduit for the tumor into the airway. So I really try not to be proactive with tracheostomy, and that's sort of a intervention of last resort. So for me, the BRAF status of this patient has a huge urgency. And then, an assessment of the airway and whether, as a surgeon, I can sit back and potentially take advantage of targeted therapy in this situation.
Right. I think, Ellie, you're very wise. In fact, ATA guidance is to actively try to avoid tracheostomy just because of how miserable it can make the patient. So unless it's, of course, necessary. Right.
Yeah. So
Dr.
go ahead. Sorry.
Angie. Go ahead.
I was just going to say that she wasn't in any extremis and was able to kind of maintain her airway okay, which allowed us to get testing. So we did rapid mutational testing with IHC, and she was BRAF positive. Additionally, she was TERT positive and P53 positive. So we, as soon as we got those results, started her on triple therapy with dabrafenib, trametinib, and pembrolizumab.
Angie, can I hold you for just a second? Maybe I can
Yes,
ask
sir.
as well. Would you consider adding immunotherapy standard of care in this scenario, or would you consider just BRAF MEK inhibition more of the standard?
I think just BRAF MEK inhibitors are the standard of care. I think that this patient was on trial for this, so that's why she was on the triple therapy.
Got it.
I will comment that we have kind of moved towards the triplet as standard of care in the
Got
last 2 years, even outside of trial.
Okay, sneak peek for the future. Okay. Go ahead,
Any
Ken.
thoughts? Okay, so I'll move on to the next slide. So this is 3 months of systemic therapy. And the read on the PET scan was essentially a near complete metabolic response
Oh my gosh.
to the systemic therapy. So curious what people would do after seeing this.
Sure. Dr. Shah, looks like they hit a home run. But the question is now what would you do next?
Well, this is an excellent response, and I must say, I would like to congratulate Jen and her colleagues at MD Anderson. They have done a fantastic job. And I heard in the ATA they presented recently with the addition of Pembro has survival difference. So I congratulate you for that. I would look forward to seeing the manuscript. But I think, some of the points that Kenji brought are very important. When this patient comes to the hospital, there are 100 emails go out. And everybody's prepared. It's like an enemy coming to your house. You're ready with everything. And everybody is ready to see the patient drop everything and do everything. Even if the patient had a needle biopsy outside, just don't waste time on getting those slides. They will come after 3 days or 5 days, get another needle biopsy, get the inform the cytologist to do the BRAF, and you are ready with the treatment within 48 hours. Try to avoid the tracheostomy, as Eli mentioned very elegantly, as best as possible. I don't think we have any data today with securing the airway with this kind of treatment, but what we have seen is their airway improves remarkably. We had patients with a tracheal invasion, and you do the repeat CT scan, the invasion, tracheal invasion is almost normal. So where do we go from now? He has done very well after 3 months. And this is where I don't think we have right answers, but I follow the lead taken by Mark Zaffario and Jenny about considering total thyroidectomy. If the distant disease is minimal and has responded very well, I don't want to operate on the patient and have the patient die of distant disease in the next 3 to 4 months. If there is a good response, I would consider total thyroidectomy. Majority of the time, what we have found, and I think the MD Anderson also published, that the anaplastic component is gone, and what you are left with is a papillary component. That's not uncommon. We have seen that several times. And I would consider, if technically it looks like easy, I would repeat a CAT scan. I wouldn't go only with the CT, with the PET scan. The PET scan will give me better perception of the disease. I'm sure you have done it before operating on the patient or before deciding where we go. And within 3 to 4 months, I would make a decision which way I want to go.
Great. Sounds like that 3 to 4 month window is kind of what you're anticipating. I think probably that's the MD Anderson model as well. So Kanji, do you want to?
Yeah, Dr. Shah, I think you hit this on the head. So she did undergo surgery. She had a total thyroid, bilateral central compartment dissection, and then bilateral lateral neck dissections. And in the specimen, it was histologically identified as PTC with infiltrating follicular and conventional histologic subtypes. She did have some tumor in some lymph nodes still, but again, no ATC identified, just PTC. And then post-operatively, her scope exam looks fantastic. Normal vocal fold movement, no swallowing issues, and a lot of her edema had died down.
Gosh.
Hey, Jen, can I pose a question to you? I know that the retrospective data from your institution show that doing a rest or salvage thyroidectomy leads to better outcomes. But time and time again, we see that the pathology report just shows conventional or less aggressive papillary thyroid carcinoma. You would think the rationale to do the surgery is to capture resistant ATC clones, right? That will one day, escape. But this path report didn't seem to validate that. Do you think that one day we'll get to a phase where we don't have to do a salvage thyroidectomy?
Yeah, thank you for that question. And that's actually exactly the paper I'm working on right now. I'm trying to get it wrapped up and published. So I do think that based on what we're seeing currently for BRAF mutated ATC, surgery actually has a pretty important role, because in the patients we've studied serially baseline on treatment and recurrence, the patients that have recurred, what is scary is that their tumor from the very beginning had these really rare subclones that then became resistant and kind of expanded out during therapy. And some of these patients just had PTC left as surgery, right? So I think that there unfortunately is such a rare fraction that we might not necessarily be detecting them, even the surgical specimen. Just because they look like PTC doesn't mean that they're truly molecularly PTC, and that they don't have this capacity to further evolve. That's sort of the sneak preview.
Okay. Got it. Okay. And then Kenji, I don't know if you were in the case, but if you could describe the nature of these surgeries, because I hear sometimes it can be quite challenging.
I was not in her case, but I have done one of these cases, and it's Not fun, a lot of scar tissue. Just trying to identify things that we know and taking things that don't belong there.
Okay.
Some
Sorry,
of these
Henry.
patients get metaplastic reaction,
Yeah.
and that may be a little bit annoying and difficult for the surgeon. These are the kind of cases you need starting from 8 to whatever time. Don't book another case. Don't start the case at 2 o'clock in the afternoon when the fellows have to go home at about 6 o'clock. Just spend a whole day on this case.
Right.
I will say that we use a PET scan quite a bit because interoperatively, like what Dr. Shah is saying, everything is just sticky and it's hard to know what's tumor, what's not. So having a PET scan, I think, is really, really critical before surgery to help you determine what you really need to worry about. For example, if something's like on the esophagus and you need to decide how far into that you need to dissect based on the PET scan.
Great. Ellie, we've had two good lucky scenarios with this patient, both with the induction therapy, but also the surgery. What are you going to counsel the patient about how to proceed?
Thank you, Alan, for that. As I was listening to Jen, the MD Anderson crew, talk about this fantastic, result, I was thinking, okay, this is pretty extensive surgery in the neck, and I know just having listened to MD Anderson team discuss their experience, there is an urgency to get restarted on these targeted therapies right after surgery because of the concern that the metastatic disease is just going to surge back off of treatment. So just curious, how do you manage in terms of timing pre-op coming off of the medications and post-op going on the medications? And then once you're done with surgery, what does adjuvant look like? Do you go forward with a chemoradiation approach, or do you continue with a BRAF inhibitor approach or immune therapy approach or combination?
Go ahead, Jen or Kenji. What do you guys do?
Do you want to take a stab and then I can fill in?
No, I'd like you to take a stab and I'll fill
Okay,
in.
okay. All right. So generally speaking, for BRAF inhibitor, for the dabrafenib, we actually don't think it has wound healing complications really. So we give it up right until the surgery. So the patients even get it the day before. The trametinib, we like to hold a bit longer. So typically about like 4 days before surgery, we have them stop it. The pembrolizumab, that part is still a bit variable, like I don't hold it, and my patients have done fine, but others, they are holding the dose before surgery. So that's TBD. And then in terms of what to do after surgery, there really is kind of dependent on each individual case. Generally speaking, though, they almost always go back onto the triplet. And we don't necessarily, radiation could be considered in some cases, particularly in the patients that don't have distant disease. But generally speaking, even in those patients, they go on DTP. We have had several patients now who are many years out, and we are thinking about maybe stopping it in some patients, but we really haven't been brave enough to really try to systematically look at that question. But that would be the next frontier. The question of whether radiation could be administered safely with the dabrafenib trametinib is something that we're currently evaluating in the trial setting. We don't really know whether the dabrafenib trametinib increases radiation-associated toxicity.
Thank you, Jen. So my understanding is in BRAF positive patients who've had a good response to the triple therapy, postoperatively, you continue with the triple therapy, and the chemoradiation is more geared towards people who are BRAF negative.
In certain patients with 4B, we will do radiation, right? But we don't, what worries us in that setting is that as standard of care, in order to do that radiation, we have to take them off of the targeted therapy. So we worry that they're going to progress in that time frame. And in fact, I think in our early experience, we did see that. So now, we are trying to figure out if we can safely give radiation and targeted therapy in a trial setting. But as a whole, I think we lean towards prioritizing targeted therapy over radiation, if that makes sense. Unless we really think they're going to benefit from it.
Excellent. Well, it's great to have a happy ending for this case. This wraps it up. All good things must come to an end. So Chris, Michael, and Kenji, thank you and congratulations for presenting some excellent cases. I can tell the future of our specialty is assured. So I'm going to hand it off to Mike, who I think is going to talk about the next session. Mike, are you still there?
Yeah, I'm still here, Alan. Thank you so much. And really thanks to all the presenters. These were tremendous cases, really kind of walk through a lot of the nuance and also kind of exposes us to a lot of the amazing work that's being done around the country to really help patients that in the past, I remember when I was in training, these were death sentences. So really kudos to all of you who are on the front lines and finding great ways to treat our patients better. I know I always learn a ton just from listening to this group. So thanks for being a part of it. So next session will be on December 4th. It'll be focused on cutaneous malignancies, evolving treatment approaches to non-melanoma skin cancer. Hopefully see many of you there. So thanks again and have a great Thanksgiving, everybody.
Thanks, Mike. Alan,
Yeah.
feel better.
Excellent.
Yeah.
Thanks,
Nice
everybody.
meeting you.
Thank you,
Thank you.
Mike.
Take care.
And thanks for your comments. Enjoyed them.